Okay, so before we go to the lunch break, I'd like to introduce Stefanie Hectors. She's a PhD. I had the pleasure to work with Stefanie. She's a postdoc. She's been here over a year now. She trained in the Netherlands. She had a background in preclinical multiparametric MRI, and she's been working mostly on human, imaging. And I think position has been good so far. So she's going to talk about assessment of tumor heterogeneity in HCC using combined DCE-MRI and BOLD measurements.
Well, thank you for the nice introduction. So in this study, we assessed tumor heterogeneity in HCC using combined DCE-MRI and BOLD measurements. Tumor perfusion and oxygenation are two important tumor characteristics that can largely influence treatment outcome. For example, a hampered tumor perfusion will lead to a poor delivery of chemotherapy pre-chicks, and also hypoxia can lead to a less efficient radiotherapy. Well, both characteristics can be measured non-invasively using MRI. Perfusion can be measured using DCE-MRI, and oxygenation can be measured using a technique called blood oxygenation level dependent or BOLD MRI. Well, tumor heterogeneity exists on a genetic, molecular, and a cellular level and occurs during the development of tumors and also as a response to treatment. It has been shown that histogram analysis of MRI parameters is promising for the distinction between different cancer subtypes and also for the prediction of treatment response. And therefore, we suggested that pixel-wise histogram and regional analysis of DCE-MRI and BOLD MRI data could give information on perfusion and oxygenation heterogeneity in tumors. So the goal of our study was to assess perfusion and oxygenation heterogeneity in patients with hepatocellular carcinoma, or HCC, using DCE-MRI and BOLD MRI. In this prospective study, we enrolled 37 patients with HCC, of which we needed to exclude 9 patients because of various reasons. So finally, we included 28 different patients that were scanned either on our Siemens 1.5 Tesla ERA system, the Siemens 3 Tesla MMR system, or the Siemens 3 Tesla Skyra system. Here you see an overview of the MR acquisition parameters. For the DCE-MRI acquisition, we used a 3D flash sequence in an axial orientation. This was done with an average temporal resolution of 2.3 seconds, using 64 to 100 dynamics, and during this acquisition we injected multi-hands contrast agent. The BOLD MRI acquisition was done using a multi-echo gradient echo sequence before and after oxygen challenge, and this acquisition was done using 5 to 12 echoes. For the DCE-MRI analysis, we used a baseline T1 mapping sequence from a separate acquisition, either a variable flip angle or a look-locker acquisition, and this acquisition was co-registered to the DCE-MRI data using a landmark-based registration algorithm in MATLAB. This was done in all slices for which our T1 mapping was available, which were 1 to 2 slices for the look-locker scans, or full coverage for the VFA scans. Subsequently, we converted each dynamic signal intensity curve in each pixel to contrast agent concentration using the SPGR formula, and fitted these curves to a dual input single compartment model, which led to estimations of arterial flow, portal flow, the distribution volume, the mean transit time, and the arterial fraction. And here you see an example of these maps in the liver, in which the lesion appears as a region with high arterial flow. The BOLD MRI analysis was done using fitting of a mono-exponential model to the multi-echo data, which led to estimation of R2 star, which is low in normoxic tissue because of a low concentration of deoxyhemoglobin, which is paramagnetic, and high in hypoxic tissue because of high concentrations of this molecule. The anticipated effect of the oxygen challenge was that there is enhanced saturation of hemoglobin in hypoxic tissue, which will lead to a R2 star drop. And here you see examples of the R2 star maps pre and post the oxygen challenge, in which the tumor is delineated in white, and we clearly observed regions in which the R2 star decreased after oxygen, which is indicative of presence of hypoxic regions in the tumor. Subsequently, we co-registered the BOLD MRI and DCE-MRI data using a landmark-based registration algorithm in MATLAB. and that was done for each slice and for the pre- and post-oxygen acquisitions separately. This registration consisted of 3 different steps. First, the R2 star slice that matches the DCE-MRI slice was chosen. Subsequently, the DCE-MRI and R2 star maps were co-registered by manually defining landmarks that were present in both images, and then the registration was checked visually. After this registration, we positioned the ROIs in the HCC tumors on a native DCE-MRI image and propagated these maps, these ROIs on the DCE-MRI and BOLD parameter maps to avoid inclusion of artifacts or non-tumor tissue. Well, in these ROIs, we defined all parameters, so all DCE parameters, the R2 star pre, R2 star post-oxygen, as well as a delta R2 star measurement, which is the difference between pre and post-oxygen. And then in these global ROIs, we assess the mean, median, kurtosis, and skewness of all these parameters, and the latter two are a marker of heterogeneity within the tumor. So, and this is schematically shown in these histograms here. So if there is a positive kurtosis in a distribution, it means that the distribution is more peaked than a regular Gaussian distribution. While skewness means that there is a clear tail towards either the left or the right side of the distribution. In addition to the global ROIs, we also looked at segmented ROIs to account for heterogeneity in the tumors. For this, we divided the ROIs into either 1, 4, or 9 segments, dependent on lesion size. And then we determined the mean and median of all parameters in these segments. We also compared our results to pathology, which was available for 14 patients. 1 section per tumor was analyzed using multiplexed immunohistochemistry, using the following markers: CD31 as a marker for vascular endothelium, CD3 as a marker for T cells, and CD68 as a marker for macrophages. And here you see a representative microscopy image of a CD31 stained tumor section in which vessels are stained red. And then we applied a custom-written threshold-based segmentation to segment stained pixels. For this, we converted the images to red, green, and blue channels and scaled them and applied the thresholds, which is defined here. And here you see the results of this segmentation, in which you see that the stained pixels are indeed identified correctly. And based on this, we determined the stained tumor fractions, which we could correlate to our MR parameters. So the statistics we have done were Spearman correlation tests between the DCE-MRI and BOLD MRI quantitative measures in both the global and the segmented ROIs, as well as correlations between MRI parameter values in the global ROIs and pathology stained tumor fractions. Now here you see an example of the parameter maps obtained in a single tumor. So this parameter map is zoomed in on the tumor. And we clearly observed in a lot of tumors that there were 2 distinct regions, regions with high arterial flow and that corresponded with low R2 star values. So these regions are probably well perfused and normoxic, while there were also regions with a low arterial flow and a high R2 star, which are probably poorly perfused and hypoxic. Here you see histograms of the same tumors, of the same tumor as showed on these maps, and we indeed observed 2 clear distributions in these histograms, both in the DCE-MRI parameters and also in the R2 star maps, which is indicative of high heterogeneity in these ROIs. Here you see the average parameter values we obtained in the global ROI, so in the entire tumor. We observed that the arterial flow was generally higher than the portal flow in HCC, which is typical for HCC tumors. And also we observed a decrease in R2 star post-oxygen, which indicates the presence of hypoxia. Now for the correlation in the global ROIs, we didn't observe any correlations between DCE, MRI, and BOLD parameters using the mean and median values. While we did see some significant correlations between these parameters when we used kurtosis and skewness, which means that BOLD MRI and DCE MRI exhibited a similar heterogeneity, but the values itself didn't correlate on a global level. Well, when we used correlations in segments, so the subdivision of tumor into a few segments, we did observe significant correlations between mean and median DCE, MRI, and BOLD parameters, while they were just, so like I said before, absent in the global ROIs. So here you see those significant correlations, although they are pretty weak, they were significant. So there was a significant negative correlation between the arterial flow and the R2 star pre and post-oxygen, both for the mean and median. And for the correlation, we also observed a strong, significant negative correlation between the CD31 vascular fraction and the mean R2 star pre and post-oxygen, as shown here, which indicates that BOLD MRI measurements can probably predict the amount of vasculature in the tumor. So we observed a large heterogeneity in DCE-MRI and BOLD MRI parameters in ACC lesions, and we showed that the global ROI measurement is not sufficient to characterize tumor perfusion and oxygenation, and also not to assess the correlation between DCE-MRI and BOLD MRI. However, we did see significant correlations between DCE-MRI and BOLD when we used the segmented ROI measurements, although those correlations were still weak, even in the segments. This could be probably explained by the fact that DCE-MRI and BOLD MRI probe different yet related tumor properties, and also heterogeneity may still be present in the segments, though to a smaller extent. Now, this study has a few limitations, including a small sample size, the lack of exact geometric match between the DCE-MRI and BOLD MRI measurements, although we performed co-registration. And also the pathology was only available on a single section of the tumor, and there was variability in field strength between patients, which may need to be corrected for. So in the near future, we also want to incorporate a visual assessment of DCE-MRI and BOLD MRI heterogeneity by objective readers, and add additional histological stainings, specifically the hypoxia marker HIF-1 alpha. And also we want to correlate our data with HCC genomic assays that were currently done. So to conclude, histogram and segmented ROI analysis of DCE-MRI and BOLD MRI data can identify regions with distinct perfusion and oxygenation. We think that this technique could ultimately be used for treatment stratification and monitoring of HCC tumors and tumors in general. So thank you for your attention.
Thank you, Stefanie. Nice work. So are there any questions? We can take one question if there's any before lunch. Okay, no questions. Well, I'd like to offer you this nice certificate of recognition and small gift. So thanks very much.